Welcome. I'm Susan Claffey. I'm Director of the Office of Graduate Services at AACPM, and this is a continuing medical education offering by the AACPM Council of Teaching Hospitals. Today's presentation is on GME funding for your residency program and is being presented by Dr. Melanie Violand. Dr. Violand graduated from the New York College of Podiatric Medicine in 2000. She completed a 3-year podiatric medical surgical residency at Wyckoff's Medical Center in 2003, where she served as chief resident. Dr. Violand is board certified in foot surgery by the American Board of Foot and Ankle Surgery. She serves as the Associate Dean at Midwestern University, Arizona College of Podiatric Medicine. Dr. Violand also serves as a council member on the Council of Podiatric Medical Education. Dr. Violand, thank you for agreeing to do this presentation, and I now turn the presentation over to you.
Okay, thank you, Susan, and thank you to COTH for inviting me to do this presentation. So today we're going to discuss graduate medical education funding as it pertains to podiatric residencies. Here are my disclosures that Susan already shared. And we're going to review CMS funding for a residency program. We're also going to help you identify your specific hospital funding report. We're going to help you evaluate your resident rotation schedule so you're maximizing GME funding. We're going to discuss GME funding and how it pertains to transfer residents, terminated residents, and fellowships. And we're going to discuss how you can pay for your teaching faculty. And then at the end, we will provide additional resources for GME funding in case you wanted to dive into any of these areas a little bit deeper. So it's important to recognize that GME funding comes from 3 main funding sources: CMS, or federal CMS funding, Medicaid, particularly the state level, and then we have another category. So this may include private payers, the VA, teaching hospitals themselves, grants, and foundations. So the Centers for Medicare and Medicaid Services, or CMS, actually has an opportunity for sponsoring institutions to request GME funding. This is an accounting function. It's commonly done through the CFO's office, and they are going to request GME funding on the hospital's annual cost report. So this is not necessarily an accounting function that the podiatry residency director would do. Rather, it's done through the hospital and through their appropriate administrative office. It is important to recognize that all GME funding requests are subject to Medicare audits. There are 2 major types of payments that CMS offers to residency programs. One is the direct graduate medical education payment, and the other is the indirect medical education payment. The direct payments are meant to cover the cost of running the program, and the indirect payments are meant to cover the complexities with having residents take care of patients. So some specific examples that are meant to be covered under direct GME would be the resident salary and benefits, their malpractice insurance, program coordinator salaries, compensation for the teaching physicians, recruiting expenses, accreditation fees, in-training exams, and other overhead costs. Theoretically, IME payments are meant to cover the excess costs of care due to a resident's inefficiencies. So residents tend to order more tests. Patients being taken care of by residents tend to have longer lengths of stay. These sicker patients often require more advanced technology. So that's what the IME payments are meant to cover. So direct payments vary for each hospital. They are based on an amount known as the per resident amount. They're based on the number of residents a hospital is allowed to claim. This is called the resident cap. We'll discuss that in a little bit. Direct payments are also based on the hospital's percentage of inpatient population that is comprised of Medicare beneficiaries, and direct payments are updated each year with an inflation factor. So how are the direct payments calculated? So as we mentioned, the per resident amount is adjusted annually for inflation, and then you multiply the PRA by the full-time equivalents in the hospital for that current year, and then you multiply that number by the hospital's ratio of Medicare inpatient days divided by total days. Indirect payments compensate teaching hospitals for higher operating costs due to the patient complexity and other costs associated with being a teaching hospital. So things take longer because you have learners as part of the process. IME is actually an add-on payment, and the IME is based on a formula using the intern to bed ratio. The intern to bed ratio measures the teaching intensity of a hospital. It's also important to recognize that IME payments tend to be much higher than direct GME payments. So let's look at the state level. So Medicaid funding for each state can vary. Reimbursements usually tied to budget allocations, and some states have a separate indigent care fund. So funding at the individual state level may provide additional support for GME. State GME funding is often tied to legislation and therefore can vary annually with budget discussions and state appropriations. Some examples of states that make additional GME payments include Texas, Michigan, Wisconsin, and Florida, and this list changes regularly. When we're discussing support at the state level, it's also important to recognize that there is a disproportional share payment offered by Medicaid, and this is intended to offset uncompensated care to improve access for Medicaid patients and uninsured patients. In the fiscal year 2020, Medicaid made a total of $19.5 billion in DSH payments, $8.2 billion at the state level, and $11.3 at the federal level. Teaching hospitals tend to receive the majority of DSH payments. I do think it's very valuable for program directors to know what their hospital is receiving in GME funding, or at minimum know what their PRA is. That will help directors have valuable conversations with hospital administration when it comes to developing your podiatry budgets. So to find your specific hospital PRA or GME funding for a particular year, you can go to the Graham Center website. This link will bring you there. When you get to the website, you want to scroll down to where it says download the data from fiscal years. Currently, the most up-to-date year is 2018. 2019 should be coming online soon. For our purposes of today's presentation, I chose North Colorado Medical Center because we did a similar presentation with Dr. Vardal a couple years ago. So you would select your state down here. So we selected Colorado. We're going to find your hospital, North Colorado Medical Center. And then we're going to hone in on the relevant columns. So this is for fiscal year 2018. You can see that DME funding was $1.84 million for that year. IME was $3.53 million for that year, for a total of $5.37 in GME funding for that year. It's also important to note that their non-primary care, which would be podiatry, per resident amount was 123,516. So that's an excellent PRA amount, and that's important for you to know as a residency director. So when does the hospital receive these direct funds? Well, the direct payments are made on a biweekly payment throughout the year, and then it's reconciled on the cost report when the hospital submits the FTE information. So if you want to record how much you spent paying your faculty, how much the resident salaries were, how much malpractice currently is for your residents, you can record this in a separate cost center. It is a part of the cost report, so it can be referred to, and that way you can easily identify the total costs that you're spending for your residency. It should be noted that little attention is paid to the cost center for reimbursement purposes. Reimbursement is driven by the factors we discussed earlier, like the per resident amount and Medicare days, etc. But it is important to recognize what you're spending on your residency budget. We often get inquiries about new programs and how funding is affected by a new program. You should recognize that any new program has to go through a 3-year rolling average, meaning the hospitals do not receive full funding during the initial 3 years of the program. So the COTH website actually offers this gap calculator, and you can put in your per resident amount, you can put in salaries, and try to estimate how much you will have to make up for in your budget, because you will not receive full funding until year 4 and 5. So the cost reports are based on the residents' time that they are spending involved in patient care. The sponsoring institution can only claim time for the residents when the residents are in the sponsoring hospital or when they're in a non-hospital, non-provider-based setting. So for example, the sponsoring institution can claim time if your resident is rotating at a privately owned surgery center. If the residents are rotating through another hospital, the sponsoring institution cannot claim that time, even if the other hospital is not claiming the time. A sponsoring institution can claim time a resident spends on a formal rotation caring for patients in a non-hospital ambulatory setting. So for example, if the residents are rotating through a private podiatry office, you just have to make sure that you have an affiliation agreement or a letter of affiliation in place. And you have to make sure that the sponsoring institution is covering the salary and benefits of the resident for this time. It's important to recognize when you cannot claim time. You cannot claim a resident's time when they're at another hospital or at another provider-based clinic. So an example of a provider-based clinic would be if they're at a surgery center that's owned by the hospital, that's considered a provider-based clinic. And if it's a clinic not owned by your sponsoring institution, but it's owned by another hospital, you can't claim the resident time there. If the sponsoring institution is not paying the salary and benefits for the resident, they can't claim that time. If a resident is spending time outside of the US, let's say they're doing an international mission, you cannot claim that time. You cannot claim time for a strictly research rotation that doesn't involve patients being cared for by the sponsoring institution. And finally, you can't claim time for non-educational weeks that extend a residence training program. So the most common example would be parental leave, maternity leave. So how can you make sure you're accounting for your resident time accurately? So there's a software system out there, Intern and Resident Information System, and it will help you account for each half day of your resident. So the IRIS software is an add-on for new innovations. So if your hospital is already using new innovations, they likely are also using the IRIS system to count resident time. You can submit this IRIS report with your funding request with your cost report. And you must also make sure that your rotation schedule is supporting this IRIS report. So the basis for Medicare audits is resident rotation time. So you want to make sure your report for your request for GME funding is matching your resident rotation schedule. Now, when a resident is claimed by multiple hospitals, which is common throughout the same year, you want to make sure that everybody's identifying the appropriate time for the resident. You don't want to be claiming the same time another hospital is claiming. Medicare does do an overlap report to catch this. So you want to evaluate your rotation schedule to make sure you're maximizing GME funding. How can you do this? Well, we just talked about accurately tracking your resident time. You want to have organized rotation schedules. You want to move didactics and research into the sponsoring institution. And you want to minimize the amount of time a resident is spending in a provider-based clinic that is not linked to the sponsoring institution. And if you're using non-provider-based clinics or non-provider-based surgery centers, you want to make sure that you have the appropriate affiliation agreement in place. Rotation schedule should be very detailed. You want to capture any time a resident is away from the sponsoring institution. And conversely, if a resident is on and out rotation and then comes back to the hospital for didactics, you want to make sure you're recording that as well. We've been getting a lot of questions about transfer residents. So it's important to recap that the sponsoring institution that trains the resident is the one that is eligible to receive the CMS GME funding. Therefore, the hospital that's receiving a transfer resident will benefit from receiving the additional funding since they're the ones adding a resident to their current number of residents. The hospital losing the resident cannot claim CMS funding for that transfer resident. So the last day of training for that transfer resident is the last day the hospital losing the resident can claim that resident for CMS funding. Similarly, with termination of residents, when a sponsoring institution terminates a resident, that institution can no longer claim that resident for GME funding. So it's important to recognize when the resident was terminated, and it's also important to recognize when the resident may have gone on a leave of absence before they were terminated. So you can't claim time for when that resident was on their leave of absence either. Recently, Susan and I have been getting a lot of emails about fellowship GME funding, and so we want to take the opportunity to address it here. So if a fellowship is approved by CPME, then the hospital can request GME funding on the Medicare cost report for that fellowship. It is important to recognize that fellowships receive 50% of direct GME funding and 100% of indirect GME funding. Now, if the hospital is claiming the fellow on the cost report, that means that the fellow cannot bill for services just like a resident. So, of course, you do not have to claim fellows on GME funding requests. And then you can then allow the fellow to bill if that is what your hospital wants to do, but you can't do both. We often get questions about teaching time for faculty. So the short answer is it's completely up to the program how they want to compensate physicians for teaching the residents. Physicians are supposed to maintain a time study that identifies when they're teaching, when they're doing administration, and when they're doing patient care activities. So if a physician is supervising residents in a clinic, but the physician is also billing for the services they're rendering to the patients, that's not considered teaching time. So you do want the physicians to maintain time studies, and then the program can compensate them how they wish. You can record this in the cost center, But again, reimbursement is driven by the per resident amount and Medicare days and other factors that we discussed earlier. For new programs, we often are asked to confirm that podiatry residents are exempt from the resident cap. They are indeed still exempt from the resident cap. Who knows, that may change in the future. Dental and podiatry residents are currently exempt from resident caps right now. Each hospital has a maximum number of FTE that they're allowed to claim for allopathic and osteopathic residents. This was cited in the 1997 Balanced Budget Act. In the 2010 Affordable Care Act, caps were redistributed because some hospitals weren't using their residency slots, and then some hospitals had closed in a region, therefore giving other hospitals an opportunity to increase their cap. If you need to provide supporting documentation to your hospital administrators, COTH has the link that you can find the statute. And then here's a copy of the statute right here as well. And the highlighted portion says residents in dentistry and podiatry are exempt from the cap. So as I stated at the beginning, you may want to dive deeper into some of these areas. I think the Association of American Medical Colleges, they have a 4-part primer. I think it's excellent. I think it provides a lot of details that will help you become more familiar with these conversations with GME funding. I also appreciate all the resources that the Council of Teaching Hospitals has posted, and I think you'll find some examples there that will really help you have these open discussions with your hospital administration. I do want to acknowledge Mr. Dale Deach. He has joined me on some of these presentations. He's a director at PricewaterhouseCoopers. And for his clients, they provide accounting services for GME funding. They also provide accounting services for their clients who may have faced a Medicare audit as it pertains to requests for GME funding. I've provided my resources. And then I encourage you to email me directly or email Susan, and she'll make sure I get your questions, and we will do our best to answer them. And if we can't answer them, we will try to find someone that can. Susan, I'm going to turn it back over to you.
Thank you so much for this presentation, Dr. Violand. It's something I get questions about every year, and I can only imagine the number of questions that you get. I do have a couple questions that I hope you will indulge me with.
Yes.
Do I correctly understand that if, for example, I'm the sponsoring institution and my per resident amount is $120,000, but the resident only spends 80% of their time with me, does that mean I get 80% of the PRA?
So since direct payments are based on time spent in the hospital, so they're FTE, to make things simple, if they're only spending 80%, you're going to get about 80%. But we also have to remember that they also include those Medicare ratio days as well.
And then another question, because I sometimes get calls from residents who are unhappy at their current residency and they want to transfer. And occasionally one of them will ask me about repeating a year. If they would transfer to another residency and repeat a year, is there some type of impact on the funding for that resident?
That's a great question. And yes, unfortunately, there is a negative impact on the funding, because podiatry residents right now, it says you need the 3 years to complete a podiatry residency. Therefore, that resident is only eligible for 3 years of funding. They will get some funding for their year that they repeated, but that would technically be their 4th year. by the time they finish. So they get a lesser amount of direct funds, and it's my understanding they still get the full amount for the IME funding. So, but the longer the resident takes outside of 3 years to complete, there is a decrease in funding as it pertains to the direct funding.
Thank you for that. I always try to counsel them as best I can when they call about these things, and that's one of the things I tell them that they need to be sure that they have an awareness around. So thank you very much. I love the fact that we are recording this, and so it'll be handy for people to access in the future. So again, my many thanks, and we will be talking, I'm sure, in the future more about GME funding. It comes up every year.
Thank you for the opportunity. Thank you.
If you have questions about GME funding after watching this presentation, please send your questions in an email to Susan Claffey at sclaffey@aacpm.org.